Good afternoon. Happy New Year to all. I am Dr. Avinash, consultant anesthetist. So, respected dignitaries, esteemed faculty, and my dear colleagues, it's my great pleasure to welcome you all to Curiosity, the series on perioperative medicine, enhanced recovery after surgery at Curie Hospital, OMR. So, Curie has been established itself as a leading center for high quality, patient centered care along the OMR corridor. With its advanced infrastructure, state-of-the-art technology, the robotic system, and dedicated medical team, Curie Hospital continues to deliver excellence in healthcare. Over the years, Curie has grown into a trusted name, offering advanced urology, uro-oncology, nephrology, surgical gastro, and robotic surgery, with a strong commitment to quality, safety, and compassion. Few months ago, we had celebrated the successful completion of 1,000 plus robotic surgeries. I am indeed privileged and proud to be a part of it. This progress is guided by a visionary chairman, Dr. P.B. Sivaraman sir, and director, Dr. Ananthakrishnan Sivaraman sir, whose leadership and commitment to innovation and academic growth has been instrumental in shaping Curie into a trusted healthcare institution. I warmly welcome Dr. Nakasamy sir, a senior most anesthetist in India and an astounding teacher for moderating this event. I also welcome Dr. Ramasubramanian sir, a senior consultant anesthetist to this event. Curie endorses this series of perioperative medicine as Curie acknowledges that our population is getting older and prevalence of lifestyle-related changes is increasing against a background of difficult socio-economic circumstances. So ERAS represents a major advancement in modern surgical care. So ERAS, the latest updated in 2025, was chosen for the CME as it highlights the evolving evidence-based multidisciplinary role of both the anesthetist as well as the surgeons. So this CME will provide valuable insights into how we can effectively implement these principles of our daily clinical practice. So we are grateful to our distinguished speakers and participants for being part of this academic program, and we are confident that today's session will be informative and enriching. Once again, I welcome you all. So for the online delegates who are logged into the Zoom, there'll be a link below. Please log into it. It's for registration and into the TNMC, for the TNMC points. Kindly do it. We'll give you a few minutes before we start the talk. Delegates here as well, there's a QR link. You can log in for the registration for the TNMC. It's a pre-conference form.
Good afternoon, everybody. First of all, wishing you all a very happy New Year, 2026. New year, new beginning. And Curie is very proud to announce its Curiosity series on the first week of the new year. So we will not compromise on giving and providing medical education as well. So that is what we wanted to say here. Anyways, thank you all of us for being here. And it takes actually, first of all, to all those who are physically present here and who are logging in. There are around 30 online entries who are logged in the meet, and many more are yet to be counting. So this just shows the amount of determination and dedication towards the education which all of you have, and kudos to all of that, and congrats to all of you for that as well. So we have an extensive panel discussion on ERAS, that is Enhanced Recovery After Surgery, and we'll begin with the first talk by our Dr. Satish sir. Dr. Satish is a senior anesthetist in Curie Hospital. He is considered as a lucky charm for Curie because after he came here, it's just been 2 months, and his entry led us to start our first, within 2 months, we are doing our Curiosity series and perioperative medicine. So thank you very much, sir. Welcome you, and you can go ahead and talk. Thank you.
Am I audible? Yeah. I'll start straight away. I'm Dr. Satish. I practice as a consultant in the field of anesthesiology in Curie Hospital, Chennai. I'm going to give a small introduction about ERAS, how ERAS is practiced in the present day. And following this talk, there'll be a brief discussion about the items that have to be covered in the intraoperative period, post-operative period, and the preoperative period by my colleagues, Dr. Shiva and Dr. Avinash. Following that, we'll be having a problem-based learning discussion on one of significant yet peculiar case that we encountered in our own practice. So what is ERAS? Has everyone really understood what really ERAS is? Is it like just removing the tubes and sending the patient home as early as possible? I am really not sure if it is as simple as this. Let's try to understand this in a little better way. So if I'm trying to find for a definition of ERAS, I go to this website that is called as erasociety.com, and the definition that is being placed in the website is ERAS is a multimodal perioperative care pathway designed to achieve early recovery for patients undergoing major surgery. They also say that it is a paradigm shift in two ways. It tries to move away from traditional practice, replacing those practices with evidence-based medicine. And second, it is comprehensive in its scope. That is, it's trying to cover all aspects of the patient's journey through the process of surgery. Still, I'm not able to convince myself that I have understood ERAS that well. The definition that has been placed here gives me some sort of a little meaning, but have I understood the core of ERAS yet? No, not yet. So I'll try to go a little deeper. This is Dr. Henry Kehelet. He is attributed with initiating ERAS as a concept. He published this landmark paper in BJA, British Journal of Anesthesiology, in 1997. The topic being multimodal approach to control post-operative pathophysiology and rehabilitation. This paper led to a lot of discussion, and from then on, the next 25 years has seen a significant revolution in how the perioperative pathway of any surgery is being practiced. So what he tries to say in this particular paper, I'll try to understand and I'll try to give a detailed explanation about how I understood this particular paper. In this paper, the recurring thing that comes again and again in this paper is surgical stress response. Whatever discussion that happens in this paper circles back to this quote unquote thing called a surgical stress response. What Dr. Henry says is, the greater the surgical stress response, it is directly correlated with delayed recovery from the surgical process. How is it directly correlatable? We'll go a little deeper. Let us come to this particular diagram. We start with what we know. We'll start with the intraoperative room. As soon as I place my direct laryngoscopy and place the endotracheal tube into the trachea, or as soon as the surgeon places his knife and incises through the skin and subcutaneous tissue, the body is going to have a significant inflammatory cascade. That is what we call as stress response, surgical stress response. The inflammatory cascade can be because of neurohumoral mechanisms, cytokines, interleukin-6, metabolic responses, sympathetic stimulation, all kinds of stuff. We'll not go into those kinds of details, but for now, we'll call it as surgical stress response. In the intraoperative period, there are only two players, the surgeon and the anesthetist. The surgeon, by virtue of his technique, can bring down the surgical stress response, and the anesthetist, by means of the various techniques that he has at his disposal, has a capability to bring down the surgical stress response. Let us assume, for argument's sake, that if the surgical stress response is not adequately suppressed, that means it is going to interfere with how the patient is going to perform in the intraoperative period. The surgical outcomes are going to be poor. And if the surgical stress response continues to be elevated in the post-operative period as well, then the patient is not going to perform that well in the post-operative period. So the surgical stress response plays a huge role in how the patient is going to behave in the intraoperative period and in the post-operative period. Let us use the same argument from the preoperative point of view. A patient who hasn't been educated well, a patient who's anxious throughout, is more likely to encounter a significant inflammatory cascade than his counterpart who's been adequately educated and who has lesser anxiety. A patient who's got unoptimized comorbidities, a patient who has got a blood sugar of more than 300, 350, who enters into this operation theater, is more likely to have a bad inflammatory cascade compared to his counterpart who has got adequate sugar control. Similarly, long duration of fasting, which is going to have significant amount of dehydration, which is indirectly going to have hemodynamic manifestations. Again, the patient is going to encounter significant inflammatory cascade response in the intraoperative period. So if we can optimize all these parameters in the preoperative period, the chances are that we are bringing this patient into the intraoperative period, wherein he is able to have a lesser surge in his inflammatory cascade. Similarly, if you go into the postoperative period, the patient is going to have significant pain because of a surgery. That patient is going to have a surge in his inflammatory processes. A patient who's been immobile for too long because of what we call as orthostatic muscle behavior is going to have an increase in its inflammatory responses. A gut that is not so mobile is not going to allow him to take food orally. The nutrition part of it is going to come down. Again, the inflammatory process is going to be elevated. And all these processes can lead to a highly thrombotic state wherein the chances for DVT is significantly elevated. So all these combined directly affects the patient's recovery from the surgical process. So what I would like to say from here is, like, if we understand the patient's journey as he travels in the hospital from the preoperative phase into the intraoperative phase and to the postoperative phase, we have multiple points or checkpoints in his pathway wherein we can intervene in appropriate way to bring down the inflammatory processes at each part of his journey. There are specific roles to be played in the preoperative process. There are specific roles to be played in the intraoperative part of it, and there are specific roles to be played in the postoperative part of it. If we manage to do all of these interventions appropriately, the chances are that we have adequately suppressed the inflammatory process throughout his journey, and the chances are that he's going to recover from a surgical insult as early as possible compared to his counterpart who hasn't had his inflammatory cascade optimized. This is again a small description about how the journey is affected because of our interventions in the surgery process, surgery journey. A patient who's been fasting overnight, if he also has mechanical bowel preparation, that means he's going to have greater dehydration. Greater dehydration, hemodynamic disturbances. Greater stress, which indirectly manifests as high increase in inflammatory secretion of cytokines. Uncontrolled diabetes, again, the same process. Immobility, same process. Ileus, again, it leads to increase in inflammatory cytokines, which directly affects his recovery from the surgery. So this is a good narrative, a premise with which Dr. Henry Cahill had published his paper. And what happened next? What happened next for the 20-25 years is a revolution. A few colleagues of Dr. Henry, with mentorship from Dr. Henry himself, formed a small group called as the ERAS study group in 2001. They subsequently formed the ERAS Society. And in 2005, they first published the first guidelines for colorectal surgeries. And what happened then was like exponential. The guidelines were validated, vetted by significant amount of RCTs, and those RCTs were vetted again by meta-analysis and systematic reviews. So there was huge traction for this concept, the concept of ERAS as a concept. So it led to more members joining the ERAS Society and more academia, and the evidence favoring the use of ERAS in perioperative pathways increased tremendously, and they were able to publish one more guidelines in 2018 and one more guidelines in 2025. In fact, this is a statement that has been got from the erasociety.com official website. They say that by following the ERAS pathway strictly in colorectal surgeries, they are able to bring down the hospital length of stay on an average by 2.5 days and bring down the postoperative morbidity on an average by 48%. This is no small achievement compared to what was happening in the postoperative period for patients about 20-25 years back. This is not only with colorectal surgeries. The traction attracted the attention of people involved in other surgical disciplines as well. If you can see here, almost every surgical discipline that is known to mankind has absorbed this idea, and they have started publishing guidelines for their own surgical pathways. This hospital is primarily concerned with nephrology and urology. And in urology, there is one surgery which elicits significant amount of surgical sympathetic response. That is the radical cystectomy. This surgery involves removal of the bladder. It involves significant amount of pelvic lymph node dissection, and there is also resection anastomosis of the small bowel, followed by formation of ileal pouch, which is brought out as a conduit. So this involves significant amount of tissue handling, which in turn reflects as increase in inflammatory cascade. So probably if any surgery has to get any sort of benefit from the ERAS pathways, it has to be the radical cystectomy surgery of the Department of Urology. So in 2013, the custodians of ERAS who were involved in urology formed a guidelines and published in the Journal of Clinical Nutrition. They came up with 13 items which were published in this particular paper. And the subsequent years saw RCT and various analysis of these particular guidelines. And one landmark paper was published in the year 2017 in the Journal of Frontiers of Surgery. This particular systematic review and meta-analysis has about 25 studies comprising about 4,083 patients. They have published that the complication rates in radical cystectomies can be brought down to the extent of odds ratio being 0.76 compared to the counterparts in which the ERAS pathways were not observed properly. The readmission rates were like odds ratio being 0.79. There was no significance in 90 days mortality and urine leakage. And this is this paper that has been published in JAMA Network for Surgery in 2017 again. And this particular paper tries to understand how ERAS performed in all surgical disciplines. It involved studies from 21 countries, 9 surgical disciplines. There were a total of 495 studies in systematic reviews and 74 RCTs in meta-analysis. They found that the length of stay inside the hospital by following ERAS pathways came down by 1.88 days, and the complications decreased by a risk ratio of 0.71. There was no significant effect on readmission rates and mortality compared to the non-ERAS pathway counterparts. So far what I've discussed are two aspects. One is length of stay inside the hospital and the rate of complications that a patient would encounter if the particular patient has been put through the ERAS pathway. Evidence clearly says that the length of stay is decreased to the extent of 2.5 days, and the complication rates come down significantly to the extent of 48% in colorectal surgeries, and the risk ratio being 0.71 in cases of other surgeries. But what happens to long-term outcomes? This is a point that can generate intense debate among the medical community. Let us take one particular example, which is cancer surgeries, cancer per se. We understand that increase in the stress response is directly correlated with the increase in recurrence chance for cancer. So if you bring down the intraoperative stress response that a patient can experience, that directly has to be, indirectly has to be understood as the chance for recurrence of his cancer in his later days should be brought down. So a few authors went about it and performed a few studies. I would like to inform here that these are single center studies. Most of them are retrospective and observational studies. They found that in 107 patients who had underwent radical cystectomy, patients who were subjected to ERAS pathways, the 5-year cancer survival was 74% compared to the control population in which ERAS was not followed. The survival rate was 48%. Again, a similar study, in this case, it's being colorectal. The number of patients who went through the studies were 350. And the 3-year survival rate was about 88% in ERAS compliant group and 76% in ERAS non-compliant group. One more study, again 5-year survival rate. A retrospective study again. In ERAS adherent group, 5-year cancer specific death had been brought down to the extent of 42%. This is like the evidence for these studies, the long-term outcomes, the survival benefit that can be accrued by following ERAS pathways. They have mostly come from single center studies and retrospective studies and observational studies. So the evidence is not so high as you would get in systematic reviews or meta-analysis, but still it gives a point to ponder and it can generate good amount of discussion in the medical community. So at the end of it, have I really understood ERAS, what really ERAS is? I believe it's a concerted group of efforts, each to be deployed in the intraoperative period, the preoperative period, and the postoperative period. As in, like, if you understand the journey a patient has to undergo when he comes for a particular surgery. He can be intervened in the preoperative period, intraoperative period, and postoperative period. And the collective result of these interventions leads to decrease in the stress response that is going to experience in this journey, which eventually leads to significantly reduced recovery from the surgery and lesser complications, and probably better survival rate in the long term. It also lends itself for a bit of standardization for the behavior of the ERAS custodians. And if there is standardization, it can be measurable. And if it is measured, it can be directly corroborated with the outcomes. And if such a measurable capability is with us, it lends itself for auditing, and it can lead to further refinement. With that, I would like to conclude. But before I stop, I've been speaking about for ERAS for the last 15-20 minutes. I just want to give two key takeaways. One is ERAS is nothing more than optimization of perioperative stress, and we have to build in mechanisms for audit and feedback for us to make the process more refined. With that, I'll conclude. Thank you.
Thank you so much, sir, for that enlightening talk. The highlight was the last slide. So how well is ERAS understood? So let's see. Throughout the course, it will be explained even more. Next talk will be by Dr. Sivaraman. So Dr. Shiva sir is an example of epitome of calmness because he has specialized in palliative care. So when all the options of treatment has gone, Dr. Shiva sir's presence and calm demeanor and soothing voice will help the patient to relieve their cancer-related anxiety and stress. So he's going to present the next talk. Before that, just one request: all of your questions, virtual attendees can put their questions in the chat box, and delegates, you can point your questions towards the end of all the sessions. All right, over to you, sir. Thank you.
Yeah, good afternoon, everyone. This is Dr. Siva, junior consultant from Department of Anesthesiology. So the most difficult job of an anesthetist is to keep the people awake. So we are expertised in knocking off the people, especially delivering a talk, that too in a post-lunch session. It's a big Herculean task. So somehow I will just keep you people engaged. Let's hope so. So as already been discussed earlier by the speaker, ERAS is nothing but reducing the perioperative stress response, thereby improving the outcome of the patients. So how does the preoperative elements helps in fastening the recovery of the ERAS? This is the topic of today's CME. So to go on with, share, screen share. Yes, of course. So without further delay, ERAS is not a burden of a single physician. Rather, it's a multidisciplinary approach which involves surgeon, who is the central core, as he comes in first contact with the patient, followed by the anesthesiologists who help in the perioperative fastening of the outcomes, followed by the staff nurse and the dietitians, to some extent the physiotherapist too. So what are the preoperative elements of the ERAS? The root of the ERAS starts as soon as the patient comes in contact with the surgeon and the surgery is being planned. So the first element is being proper counseling and educating the patient, followed by the preoperative optimization, in which the anesthesiologist plays a vital role. The next one being the preoperative nutritional upliftment to the patients. So all these three elements can be started even in the pre-admission phase, followed by when the surgery is being planned, just 1 day prior to surgery. If the patient is said to be at a higher risk for postoperative nausea and vomiting, then we can put these patients on postoperative nausea vomiting prophylaxis. And routine use of pre-anesthetic sedatives or anxiolytics can be avoided in patients. And patients who are at a high risk of thromboembolism can be put forth on this thromboembolism prophylaxis. Routine use of mechanical bowel preparation can be avoided. And perioperative fasting guidelines, which has been updated, has been put forth in the subsequent slides, and the role of carbohydrate loading. The last one being the antibiotic prophylaxis and screen preparation preoperative. So I would like to discuss each and every talk elaborately on the subsequent slides. The first one being the preoperative counseling and education. So this plays a vital role in reducing the anxiety as well as depression. The evidence shown to be moderate, but it doesn't decrease the reduction in the length of stay. So this is an RCT which is being done on the patients who are undergoing colorectal cancer surgeries. They have used a virtual reality, VR, to educate the patients and to counsel them how the process of admission and the intraoperative and postoperative period would be, so that the patient's anxiety is being reduced drastically. This is being validated using Almanston score system for anxiety. And they have found that there is a significant reduction in the perioperative anxiety, thereby improving the patient's outcome. Henceforth, the recommendation for this preoperative counseling is very strong in ERAS. Followed by the preoperative optimization, the first one being identifying the high-risk individuals. For that, we have to use a predictive tools. The most commonly predictive tool being used is ASA physical status. And apart from that, other predictive tools that are being used are National Surgical Quality Improvement Program Surgical Risk Calculator. And another tool which is being more specific to the cancer patients are ECOG, Eastern Cooperative Oncology Group's physical status. And quality of evidence shows very low evidence in reducing the mortality and morbidity, but the overall outcome is being improved. That is, the reduction in the hospital stay is being there. Henceforth, the recommendations stay strong. With respect to identification of comorbidities and optimizing them even before the surgery and planning the postoperative plan according to the patient's comorbid conditions, also says very low evidence in reducing the mortality and complication rates and the length of stay of the hospital. But even then, ERAS gives a strong recommendation to identify the patient's comorbids and optimize it even before taking up the patient for surgery. So smoking cessation, ideally it's 4 weeks before surgery, we have to advise the patient on smoking cessation and ask them to go in for behavioral intervention and nicotine replacement therapy. The evidence is very strong in reducing the mortality and complication rates, and henceforth the ERAS recommendation is strong. With respect to alcohol consumption is associated with cardiopulmonary complications, and it is associated with increased risk of surgical site infections and immunocompromised state. And henceforth, alcohol cessation is recommended 4 weeks before surgery. Even though the quality of evidence is very low in reducing the mortality and complication rates and length of stay, there hasn't been a single study which correlates the amount of consumption of alcohol with the outcome of the patient postoperatively. Henceforth, the recommendation is very weak. With respect to prehabilitation is a topic of debate because prehabilitation is nothing but a multimodal approach which involves the physical exercises, nutritional status, and psychological optimization. There has been numerous studies which shows that prehabilitation increases the functional capacity. Thereby, it also increases the walking capacity at 4th and 8th week postoperatively. But no specific prehabilitation regimens have been put forth which has shown conclusive evidence in improving the patient's outcome. Henceforth, because of this moderate evidence in improving the functional capacity, but very low evidence in decreasing the complication rates, and hence ERAS doesn't recommend on routine prehabilitation protocols. With respect to anemia treatment, as we know, cancer patients, when we put them on blood transfusion, it can lead to immunomodulation, thereby it can lead to even immunosuppression and tumor recurrence rate. This IV-ICA trial has proven that IV iron is very effective in treating anemia when compared to oral iron corrections. In IV iron formulation, the most common and most effective is being ferric carboxymaltose, which is given at a dosage of 15 mg per kg, has proven to increase hemoglobin by 0.8% over a period of 8 days. In case of limited time surgeries like oncosurgeries where the limiting period is only 6 weeks, we can't wait for a prolonged period of time. In such cases, we can use a high dose of erythropoietin analogs, that is epoetin, at a dosage of 300 international units per kg, along with iron supplementations. which will fasten the anemia correction and reduces the transfusion needs. Always remember that reserve transfusion only for refractory anemia corrections. The quality of evidence is moderate, and hence the recommendation is very strong. Moving on to preoperative nutritional care, any patient coming onto the OP, even before running up surgical protocols, we have to run up a screening tool for malnutrition. The most commonly used screening tool in assessing the patients for nutritional care is malnutrition universal screening tool, which has an highest specificity of 89% and sensitivity of 86%. European Society for Clinical Nutrition and Metabolism has recommended several screening tools, but among which the most common and most effective is being subjective global assessment and nutritional risk score, which is a questionnaire which should be filled by the patient themselves. After running all the screening tools, if the patient is found to be in a malnourished state, then this patient should be put on oral nutritional supplements targeting 20 to 25 kilocalories per kg per day with protein intake of 1.2 to 1.5 gram per kg per day. And it should be ideally started at least 1 week before elective procedures. Immunonutrition, the most common available form is IMPACT, which is available in 3 forms, provides 26 grams of protein and 20 grams of carbohydrates. Even though there are being studies which lacks more specificity towards the immunonutrients with the perioperative outcome, few studies have shown promising results on decreasing the infectious complications when they are being used in GI surgeries, especially gastrointestinal malignancies. In case of perioperative nutritional care, the preferred route should be oral, followed by enteral, and if in case it's not possible, then we have to go in for parenteral route, as parenteral route carries more complications when compared to the advantages. The quality of evidence is moderate, and ERAS recommends a strong grade for using a screening tool, but immunonutrition, because of conflicts of results, is in weak recommendation category. This is the malnutrition universal screening tool, which takes into consideration 3 major outputs, namely the BMI, the weight loss, as well as the acute disease state, which is nothing but patient in with less than inadequate nutritional intake for more than 5 days. So with this, we will just add up and categorize the patients into low, medium, and high risk. High risk people should be put forth on oral nutritional supplementations, whereas low risk people can go on for screening subsequently with the scores during their subsequent visits. With respect to postoperative nausea and vomiting, we have to find out the high-risk individuals, which is most commonly done using APFL score system. The risk factors of PONV would include opioid use, nasogastric tube drainage, anesthesia techniques, especially inhalational anesthetics, and high opioid use, longer duration of surgery, laparoscopic surgeries, especially lap choles and gynecological surgeries, inadequate fluid management, and malnutrition preoperatively. So in such cases, we have to go on with prophylaxis, which is usually done with dexamethasone or Emicet, which is most commonly used. Since dexamethasone is as effective as Emicet, it can be given at the time of induction, whereas Emicet should be given just 30 minutes prior to extubation. This granisetron is a long-acting, which has a half-life of 40 hours. Hence, it can be given even preoperatively, just 1 day prior to surgery too. Ramisetron and apripitan. Apripitan is a drug of choice for chemo-induced nausea and vomiting. The quality of evidence is high. The recommendation grade is also strong. This is an acupressure which is being recommended by the European Society of Ambulatory Surgeries, where they say like a P5 point which is being pressured, and this helps significantly in reducing the postoperative nausea and vomiting. It just lies 3 fingers breadth beneath the wrist. With pre-anesthetic sedatives, the routine use of sedatives can lead to temporary psychomotor impairment. Even a single dose of midazolam in an elderly age group can lead to postoperative cognitive dysfunction. And hence, there is only moderate evidence to show no benefit from the perioperative sedatives, and the recommendation remains weak. Cancer patients are procoagulant state, and hence they are more prone for thromboembolism. In such cases, we have to follow a multimodal approach rather than going in for only pharmacological approach. The multimodal approach involves mechanical as well as pharmacological modalities. Under mechanical, Graduated compression stocking should be applied preoperative period until complete mobilization, which means the patient, if the patient is out of bed for more than 6 hours, then it doesn't have any role in preventing the thromboembolism. It reduces the risk of DVT by 67%, whereas intermittent pneumatic compression device is most effective in preventing the DVT. It decreases the incidence by 91% on POD 1. Any mechanical thromboembolic prophylaxis has a limited role. It can be applied only up to POD 7, and beyond POD 7, it doesn't have any add-on advantages. In case of high-risk patients, we have to put them both on mechanical as well as pharmacological thromboembolic prophylaxis. And most commonly used pharmacological modality is low molecular weight heparin. Apart from that, we can even use unfractionated heparin. It should be started preoperatively, and it can be withheld 12 hours prior to surgery if in case of low molecular weight heparin, and it should be continued 24 hours within 24 hours period of post-operative period, and it should be continued until 1 month after surgery. To improve the post-discharge compliance, we can put these patients even on directly acting oral anticoagulants if we plan to discharge them immediately 1 week after surgery. The quality of evidence is moderate to high, and the recommendation remains strong. With respect to mechanical bowel preparation, it increases the risk of dehydration, electrolyte imbalance, and it has very poor patient compliance too. So routine use of mechanical bowel preparation, even in colonic surgeries, is not recommended. Rather, it can be considered in rectal surgeries wherein the stroma care is to be needed. Diverting stroma is to be needed. If mechanical bowel preparation is to be used, we can combine it with oral antibiotics as it decreases the risk of wound dehiscence and surgical site infection too, in addition to systemic antibiotics. The quality of evidence is high, and hence the recommendation remains strong for use of mechanical bowel preparation along with oral antibiotics. With respect to preoperative fasting, the recent guidelines have stated that short preoperative fasting, especially 2 hours for liquid, is more than enough for the patient, which also improves the insulin sensitivity, decreases the post-operative nausea and vomiting, and shortens the length of stay. The evidence is moderate, and the recommendation remains strong. With respect to carbohydrate loading, the most commonly used formulation is 12.5% maltodextrin. The protocol usually says to use 800 ml on the night prior to surgery, followed by 400 ml 2 hours prior to surgery. Many studies have proven that this carb loading doesn't have an extra add-on advantage over the short preoperative fasting period. And hence, the recommendation is very weak to use or to recommend routine use of carb loading. Antibiotic prophylaxis and skin preparation. So antibiotics, as we all know, the most commonly used is being cephalosporin with metronidazole, as it covers a wide range. It should be used 60 minutes prior to skin incision, but it doesn't have any add-on effect or benefit when it is being repeated subsequently, unless until the patient is having a significant blood loss or if the surgery recommends so. Say like a prolonged surgery, and the surgery is said to be having a more risk of contamination, say like bowel anastomosis and so on. The standard post-operative antibiotics has only a placebo effect, and hence it is not recommended. In case of skin disinfection, chlorhexidine is recommended more in and is more effective when compared to povidone. And there is insufficient evidence to support measures such as antiseptic showering, routine showering, or routine shaving, or adhesive incisive sheets. Routine hair removal, if at all it is being recommended, should be done with clippers rather than razors. The quality of evidence is high, and the recommendation remains strong. So to sum up with, the preoperative elements of ERAS even starts before the admission of the patient. It should be starting with a counseling and proper education of the patient, and preoperative optimization, prehabilitation, and nutritional upliftment of the patient. Followed by immediate preoperative period, we have to limit them on fasting, as well as avoid sedatives, use PONV prophylaxis for high-risk individuals, avoid mechanical bowel preparation as much as possible, and provide them on thromboembolic prophylaxis and the antibiotic and skin preparations as recommended. So with this, I just conclude my talk saying evidence discovers what works, but protocol ensures it works for every patient. Thank you. Thank you, one and all.
Thank you so much, Dr. Shiva sir. That was really enlightening talk. I think Dr. Shiva sir's talk is more focused and catered towards postgraduate for both DNB and there is surgery and anesthesia. And for MD and MS, paper 4 exam will have ERAS question for sure. But you can ask the talks, you can ask the PowerPoint from Dr. Sivaraman sir, and if he's willing, if you are good, he'll give it to you. So our next talk is by the boss, Dr. Avinash sir. He's the head of the department of anesthesia and theory, and it's his team, it's his vision, and it's his. He's the main backbone for actually starting this curiosity series in the department of perioperative medicine. And kudos to him. And his talk will be next. So over to you, sir. Thank you so much.
Thank you, Dr. Abhishek. So good afternoon, one and all. I'm Dr. Avinash, consultant, anesthetist. So today we are going to discuss about ERAS guidelines interpreted in the postoperative phase. So thank you all for attending this hybrid CME on a Saturday post-lunch session. I know this is going to be a very long topic, but it's a very interesting one too for all the perioperative physicians. So let me go on quickly. So this was a brief overview of what Dr. Satish had given you for the evidence-based perioperative pathway. And our main intraoperative goals are maintaining the minimizing the physiological stress, maintain hemostasis, reduce opioid use, and support early recovery. So these are the components of intraoperative ERAS. That is anesthetic management, fluid management, temperature control, surgical technique, tubes and drains, antiemetic and PRN prophylaxis, antibiotics, and thromboprophylaxis. So coming to our anesthetic protocol. So before we start, I would like to say proudly that we have been practicing ERAS routinely for all our robotic surgeries at Curie for the past 5 to 6 years. And we did have good outcomes. So what I'm going to talk now and discuss is what we have been practicing for these years, and we have had very good outcomes of all those. So I'm going to share both our practice as well as the evidences. So general principles, using short-acting titratable anesthetic drugs, avoid hypotension and excessive depth of anesthesia, maintaining the physiological homeostasis, that is normothermia, normocapnia, and normoglycemia, productive lung ventilation, and the lung strategies, ventilation strategies, complete neuromuscular block reversal with TOF monitoring, early emergence and rapid recovery. So coming to the technique, it's going to be either a balanced anesthesia with an inhalation agents or TIVA. Of course, there are no evidences showing clearly favoring inhalation agents over TIVA, but TIVA does have some advantages over inhalation agents like reduced POMD, reduced emergence delirium, may reduce immunosuppression and cancer recurrence, possible anti-inflammatory and neuroprotective effects, reduced postoperative cognitive dysfunction, and improved recovery scores. And cerebral and depth monitoring, that is EEG based, that is like bispectral index and entropy are recommended. This is to avoid excessive anesthetic depth and reduce the postoperative delirium and cognitive dysfunction. We do have entropy in our setup and we use it for all the major cases. Analgesia strategy are the opioid sparing multimodal analgesia like paracetamol, NE series, COX-2 inhibitors if it's not contraindicated, local anesthesia infiltration, and regional anesthesia whenever appropriate, like epidurals for major or open surgeries. And anti-adrenergic and anti-inflammatory strategies, they aim to reduce surgical stress response and inflammation. Dexamethasone plays a very key role in it for the anti-inflammatory, anti-emetic, as well as to show the reduce the inflammation and for the 90-day mortality, Dexa plays a very important role. IV glucocaine infusion reduces the length of stay, reduces postoperative ileus, reduces delirium, and improves bowel recovery. Dexmedetomidine, this is another favorite drug of mine, which I've been using for the past 6 years for all major surgeries. It has an excellent anti-adrenergic and anti-inflammatory property and reduces delirium and opioid requirement. But it does have slight bradycardia and hypotension effect, but it can be definitely titrated. Overall, the post-operative management of the patient is also much better. And neuromuscular blockade, deep muscle relaxation, especially for laparoscopic robotic surgeries. So we have to ensure the complete reversal using quantitative TOF. So these are the recommendations which strongly, the high recommendation is for cerebral depth monitoring to see the depth of anesthesia. Now coming to the lung ventilation strategies, routine use of low tidal volume, that is 6 to 8 ml per kg, and a PEEP of more than 5 is recommended for all these cases. The evidence is moderate and the recommendation grade is high. And that is the image which I showed what we are practicing. And coming to the temperature regulation, hypothermia increases surgical site infection, blood loss and transfusion requirements, cardiac complications, shivering, pain, discomfort, length of stay. And ERAS protocol, the temperature is treated as proactive and continuous. So these are a few methods which we follow intraoperatively, like forced air warming using bear huggers, warmed IV fluids using hotline warmers, warmed irrigation fluids if that is the previous one is not available, maintaining the appropriate ambient OR temperature, and continuous core temperature monitoring using any esophageal and nasopharyngeal probes. So the main considerations for this are general and neuraxial anesthesia, impaired thermoregulation. So early active warming is critical. That is the initial first 30 to 60 minutes. And coming to fluid management, our goal is euvolemia, that is avoiding both excess as well as deficit. A slight positive fluid balance on the day of surgery is weekly recommended. So fluid overload, it leads to increased surgical site infection, increased respiratory complication, the tissue edema. Therefore, it's going to make the anastomosis difficult, impaired wound healing, and delayed recovery. Similarly, dehydration also causes AKI, impaired organ perfusion, as well as hypotension and delayed recovery. So euvolemia is our main target. And these are the recommendations that showing that restricting IV fluids on the day of surgery should be avoided routinely. Similarly, no excessive fluid administration. The recommendation is against it. Now, goal-directed fluid therapy for perioperative period. So balanced crystalloids is preferred. So fluids guided by dynamic parameters. So avoid any routine liberal fluid overloading. Treat anesthesia-induced hypotension with vasopressors, not with fluids. And the goal is mainly individualized goal-directed intraoperative fluid therapy using our dynamic hemodynamic monitors like CVP, MAP, pulse pressure variation, pulse count analysis. So the target is near 0 to slightly positive fluid balance, and there's a paper showing our reference. And this is a surgical approach, as you can see rightly in the images. So minimally invasive surgery is a core pillar of ERAS. As rightly said, robotic surgery is our main domain. Directly, it supports faster recovery, fewer complications, and shorter hospital stay. Abdominal drainage. So it's routinely avoided after any uncomplicated abdominal surgery. It is selectively used only in high-risk anastomosis, difficult dissection, contamination, or bleeding risk. And it's to be removed early, that is often within 24 hours to 48 hours, if the output is minimal and there's no evidence of leak. So the guideline states that routine prophylactic use of intra-abdominal surgical drain is discouraged, given a lack of evidence to their benefit in clean and contaminated cases. So the recommendation is weak for that. And coming to antibiotic prophylaxis, it's similar to what Dr. Shiva told in the preoperative phase. That is, perioperative broad-spectrum IV antibiotics is to be administered 60 minutes before the skin incision. But some agents like fluoroquinolones and vancomycin require administration over 1 to 2 hours, and therefore the administration should begin, if possible, within the 120 minutes. So continuation of antibiotics should be based on the pathology and the contamination during the surgery and what kind of the pathology we see intraoperatively. Post-operative nausea, vomiting, it's same like in the preoperative phase. As you can see rightly, there are various risk factors that will be assessed preoperatively, like female genders, history of PONV, non-smokers opioid use, preventive strategies like minimal opioids, adequate hydration, and antibiotic prophylaxis are dexamethasone and 5-HT3 antagonists. And coming to thromboprophylaxis, this is a very important for our major surgeries as well as minimally invasive surgeries. So this stratification is based on Caprini score. So cancer, obesity, age, previous venous thromboembolism, immobility are all important predictors. So prophylaxis is not tailored. It cannot be the same for all the patients. Of course, these are the ones which we follow. Mechanical prophylaxis like graduated compression stockings, intermittent pneumatic compression devices. It started preoperatively and it's used till the patient is mobilized out of the bed in the postoperative phase. And coming to the pharmacological regimens, low molecular weight heparin is commonly used. It started 6 to 12 hours postoperatively. And the duration is for low risk surgery until the discharge, and major abdomen or pelvic cancer surgeries extend up to a month, 28 days. Now, coming to the components of the post-operative ERAS guidelines, these 7 are the important components of the nasogastric tube: normoglycemia, postoperative fluids, urinary drainage, prevention of ileus, postoperative nutrition care, and mobilization. So NG tube is prophylactically can be used for colorectal surgery, but it's not recommended postoperatively. NG tube is not recommended for elective abdominal surgeries. So why ERAS discourages routine NG tube? It delays return of bowel function, increases pulmonary complication, causes patient discomfort, delays oral feeding and mobilization. So evidence shows no reduction in ileus or anastomotic leak. So the evidence, what it says is that nasogastric tube is to be used selectively only if there's a gastric outlet obstruction, persistent vomiting, severe gastric distension, intraoperative gastric deep compression, that is the temporary for our any robotic surgeries or upper GI surgeries, and or prolonged ileus. And the evidence says that. And coming to the sugars, intraoperative and postoperative hyper and hypoglycemia should be avoided through glycemic control, though patients with elevated preoperative HbA1c. So the goal is primarily 120 to 180 with the help of titrated insulin infusion. The recommendation grade is strong. And coming to postoperative fluids, maintain a slightly positive postoperative fluid balance with weight gain limited to 1 to 2.5 kg using balanced crystalloid solutions. So there's varying evidence quality and strength of recommendation. So patients should have ongoing treatment to correct electrolyte disturbances throughout the perioperative period. So no routine prolonged IV fluids, no liberal fluid administration, and no sodium overload thereby. And coming to our catheters, that is urinary drainage. Urinary catheter should be removed within the first 24 hours after uncomplicated minimally invasive colonic surgery, and within 48 hours after uncomplicated minimally invasive rectal surgery. So the disadvantages are catheter-related urinary tract infection, patient discomfort, delayed mobilization, longer hospital stay. And there's a strong evidence for that. Prevention of ileus. This is a very important topic, and it's one of the most important point or component causing extended stay in the hospital. Like the length of stay in the hospital is extended predominantly due to this ileus. So it is characterized by delayed bowel motility, leading to symptoms such as bloating, pain, nausea, and vomiting. This condition prolongs the length of stay, increases patient discomfort, and elevates the healthcare costs. So there's a multimodal approach that will be undertaken to minimize the postoperative ileus. Though ileus per se is not a single component, all these components are linked to each other. Only the ERAS is followed right from the preoperative phase. This can be minimized. In this, if you see, goal-directed fluid therapy is a strong no. It should not be used to prevent ileus. Early oral feeding is effective in reducing the time to solid diet tolerance and time to flatus. Epidural analgesia has a role in it, thereby effective in reducing the flatus. Mechanical bowel preparation should not effective in reducing the incidence of ileus. Probiotics are effective. Selective opioid antagonists can be used. Chewing gum, it has a cephalovagal stimulation and mimics feeding that can be effective in 45% by reducing ileus by 45%. Precolopride is a selective high affinity serotonin 5-HT4 receptor agonist that is effective, has an effective role in laparoscopic surgeries. ProEase, you would have heard about it. Similarly, simulant and osmotic laxatives like PEG, Dulcolax, Bisacodyl, all these have effective role in reducing ileus by up to 22%. And coming to our favorite topic, postoperative analgesia. This a multimodal analgesia strategy, including acetaminophen, tab blocks, NSAIDs, and intrathecal morphine can be used for both open as well as minimally invasive surgery. So if you see the analgesia per se, it starts right from the preoperative period. Like patients can be given gabapentins. We do follow for some patients who are pretty anxious. We start them with gabapentins preoperatively. Similarly, acetaminophen or NSAIDs, if it's not contraindicated, can be used in the pre-op. Intraoperatively, regional anesthesia or anesthesia techniques like opioid sparing techniques can be used. And the postoperative phase, the continuation of the regional anesthetic technique should be followed. So multimodal anesthesia and opioid sparing analgesia is the main strategy for the ERAS. Excessive opioid use leads to postoperative ileus, nausea, vomiting, sedation, and delayed mobilization, and as well as respiratory complications. So these are the various multimodal routes and the recommendations accordingly. So the first Systemic and non-opioid acetaminophen NSAIDs have 30% recommendation, followed by neuraxial techniques like epidural, intrathecal morphine. And then comes the regional blocks like tab blocks. And the last one, like IV lidocaine as well as local infiltrations, have a minor role in it. So I have a step-by-step protocol for post-op analgesia where we stop multimodal non-opioid strategies. They have main strong recommendation like acetaminophen. NSAIDs if it's not contraindicated. Similarly, the surgical based on the surgical based approach or plan also changes, like minimally invasive surgery, tab block is preferred, or very rarely intrathecal morphine. We avoid epidural analgesia in minimally invasive surgeries like robotics. If it's an open surgery, epidural is the first choice, followed by tab block. Next is the use of IV lidocaine. It improves the gut recovery, and ketorolac has a very selective role in it. And opioids can be used only when there is a rescue analgesic, and it is short acting, and it is not recommended used, not used in epidural, no gabapentin, no QL block, and no NSAIDs. Post-operative nutrition care. The core principle is oral and enteral nutrition is preferred over parenteral nutrition. Early feeding, early oral diet after low GI surgery is safe within ERAS. But the evidence quality is low, but consistent clinical benefit promotes faster gut recovery, reduced catabolism, shorter length of stay. Oral nutrition supports increase the total energy and protein intake, support recovery and from surgical stress. So its recommended route is only for frail, elderly, and at-risk patients. So how do we give this? For malnourished patients, start enteral or parenteral nutrition within 24 hours. Target energy is 25 kilocalories per day, kg per day. Protein is 1.5 gram per kg per day. We do have a calculation for it based on indirect calorimetry or a predictive equation. But the most commonly used is the simplistic weight-based equation, that is 25 to 30 kilocalorie per kg per day. And parenteral nutrition, it is given when non-functional or inaccessible GI tract, inadequate enteral or oral intake, or cytoreductive or hypex surgeries. Mobilization is a very important concept in the post-operative phase. Early post-operative mobilization should be begin on the day of surgery with at least 3 hours of mobilization per day from POD1 to discharge, supported by strong recommendation. Chest physio, again, this has a very, very important role. The benefits are prevents lung complication, improves lung expansion, thereby prevents atelectasis, clears the mucus and secretion, promotes faster recovery. So there are various methods for chest physio, deep breathing exercises, incentive spirometry, chest percussion, coughing, encourages early mobilization. There's a strong recommendation for that. So thank you one and all.
Thank you so much, sir. This is an enlightening talk. So when it comes to this intraoperative ERAS protocol, so as anesthetists, they're working so hard in making, they're the silent heroes who actually do their job really well for a better patient outcome. We as surgeons, we focus only on, as intraoperative I'm talking, we focus only on our field of surgery. But the anesthetists, all their senses are working at that time, and they're working really hard to actually have a good patient outcome. It was to them as well. So our next, before we go to the next topic, so this QR code here, please use this link to register for this particular CME, because many of the virtual attendees, some of them, they are present, but they have not yet registered. So please register for their PNMC credit points. So yeah, we'll go on to the next talk. Talk is by our nephrology team, nephrology head of department, Dr. Ajay sir. So Dr. Ajay sir, okay, yeah, Dr. Ajay sir has, please read that. He's to be really to tell the truth, he's one of the youngest heads of the departments of part of India. So young age, lots of experience, and really privileged to be here and introducing him. Thank you very much.
Hello, everyone, and thank you, Abhishek, for this good intro. Right. We have had an extensive and great lecture about ERAS today, and a slight deviation from ERAS. I'm going to talk about sick day drugs today. So what about sick day drugs? So a basic intro about sick day drugs is, it was introduced in around 2010, just to avoid a preventable AKI, because when patient is sick and a chronic patient is taking multiple drugs, so diabetic patient on OHS, a hypertensive patient on hypertensive medicines, and cardiac patient on cardiac medicines. So these patients were having a lot of AKIs because when they were having some volume depletion state, because of hypovolemia, they were ending up in a lot of AKIs. So to avoid AKIs, the concept of sick day drugs was introduced by NHI in around 2010, and it was developed. And now the definition, according to them, the definition is the medication for chronic condition that should be temporarily stopped or adjusted during acute illness like fever, vomiting, or diarrhea, or any situation which could cause dehydration, which could cause volume depletion. These drugs should be stopped or adjusted according to the illness. So the newer term, the old term was sick day drugs. The new term which they use right now is sick day medication guidance. So it was introduced in 2023, and now it has been developed. And this is a new name which they are given, which is sick day medication guidance. And it is very, very crucial for our diabetic patients, cardiac patients, and our CKD patients. So mostly these drugs has to be stopped and restarted within 48 days. The main we do two things wrong. One is we don't stop it or we don't restart it. So both has to be done. It has to be stopped and restarted within 48 hours. And usually what we are avoiding here is AKI, metabolic acidosis, hypotension, and hypoglycemia. So what is the importance of this sick day drugs is to prevent AKI or kidney damage. Next is manage diabetes and prevent hyperglycemia, by which avoiding DKA, and avoiding hypotension, because when diuretics is used or any other medicines which can cause hypertension, and to maintain the fluid balance. So that is the importance of this sick day drugs. So what are the multiple associations which recommends the sick day drugs are most of the diabetic associations and the renal associations all over the world. They recommend it, from American Diabetic Association to KDIGO Association. They recommend this SDMG. Coming to what are the drugs? So the acronym used here is SADMANS. So if you remember, this slide is very, very important in the whole presentation. So first is in SADMANS, S stands for sulfonylurea, which is a OHA, which comprises of glimepiride and glycoside. AC inhibitors, ramipril, lisopril, and enalapril, that is for A. And in D is for diuretics and direct renin inhibitors. In diuretics, we know about loop diuretics, thiazides, and spironolactone. And M stands for metformin. And other A stands for ARB, as well as ARNI also comes here. ARNI is the drug which is used for heart failure. And N is for the NSAIDs. NSAIDs is a painkiller which we use. And the last drug is the star drug of the day, which is SGLT2 inhibitors, which is comprises of empagliflozin, dapagliflozin, which we use now. And these are the sick day drugs. And we will just run through each drug and few points about each drugs. So first, coming to renin-angiotensin system inhibitors, which comprises of ACE and ARB inhibitors. So basically, when there's a volume depletion, what happens? So when there is volume depletion, so there's increased angiotensin 2, which promotes proximal tubular sodium reabsorption, aldosterone. And aldosterone, as aldosterone synthesis is more, it induces thirst. So by which it increases the renal perfusion and glomerular filtration rate. So when hypovolemia is there, this is the response from the body. So when renin-angiotensin system inhibitors like ACRB or RB is there, this affects the system and it causes further hypovolemia, which can lead on to hypotension or renal failure. So this is the basic thing which happens. And in glomerular level, so we know about afferent arteriole and efferent arterioles. And basically, ACRB acts on the efferent arterioles. It causes vasodilatation of the efferent arterioles. So basically, when there is hypovolemia or hypertension, what happens is there's going to be two things. One is two response from the body. One is prostaglandin induced, and next one is RAS induced. Prostaglandin acts on the afferent arteriole, and in afferent arteriole, it causes vasodilatation. And RAS acts on the efferent arteriole and it causes vasoconstriction. And these two compensatory mechanisms are counteracted by the two major drugs, which is NSAID and ASRB. So when these two combination is there, it can lead on to further drop in GFR. So few words about NSAID. we know it is very highly used, but in nephrology, we have always have a big concerns about NSAID. So few things which can it causes, it can cause edema because of sodium and chloride retention. It can cause hypertension because of vasoconstriction. It can cause hyponatremia. It can cause hyperkalemia, and it can cause acute renal failure because of vasoconstriction, ATN. It can cause interstitial nephritis, and it can cause even nephrotic syndrome. So that is about RAS system and NSAID. Coming to the next drug, which is diuretic. So diuretic promotes volume loss, which can induce renal dysfunction and change in electrolytes. So which includes loop diuretic, spironolactone, and thiazide diuretics. We usually miss this thiazide diuretic because it is always hiding inside a hypertensive medicine. We usually tend to lose it, and we tend to miss it, and sometimes which leads on to multiple complications. So what it does is it causes dehydration, which we all know. Next is it causes hyponatremia. Thiazide diuretics is one of the common drug which causes severe hyponatremia. And hypokalemia is more common with loops, and hypotension again because of volume depletion, and of course it can cause acute kidney injury. Coming to the next drug in the sick day regimen, next is metformin. We all know metformin causes or risk of lactic acidosis. It is strongly associated with this predecessor, with a older molecule which is called fenformin. Not much with metformin, but still it can cause. There are a lot of reports it can cause lactic acidosis. It is unlikely to induce hypoglycemia. It doesn't cause hypoglycemia at all, but it can aggravate the symptoms of nausea, vomiting, and diarrhea in a already volume depleted patient, which can induce renal failure as an indirect way. Coming to sulfonylureas, the major worry about sulfonylureas, it is a very, very strong OHS, and most of the time it can cause hypoglycemia. It can have a good, we can have a very good control of sugars with sulfonylureas, but in a sick patient or in a volume depleted patient or in a patient who's not taking orals properly, it can cause hypoglycemia, and we have to be in a much more concerned about these two molecules. One is glibenclamide and glimepiride, because it has a much more renal clearances there. And the last drug and the most important drug is SGLT2 inhibitors, which has been rampantly used nowadays in our. And basically, SGLT2 inhibitor is the anti-diabetic drug. Started as anti-diabetic drug, but right now is used in even non-diabetic patients for heart failure as well as renal failure for renal protection. Basically, it pushes glucose inside the urine along with natriuresis. So it acts as an osmotic diuretic effect, by which it has some diuretic effect too. Because of that, it can have some dehydration, and it has been associated with euglycemic ketoacidosis, and therefore more can contribute towards diabetic ketoacidosis. And being in a urological setup, so we see a lot of urological patients here. It causes so much of UTI, and it can worsen up it can convert the simple UTI into complicated UTI because of this drug. And of course, because of this, we have seen a lot of AKI because of SGLT2 inhibitors. So though this drug is not a part of sick day drug, it has to be mentioned. So patients who are on chronic steroids, so because of hypothalamic pituitary adrenal axis suppression, and patients who are on prednisolone of around 5 mg per day or equivalent, they won't have a normal response to severe illness is blunted. So because of this, they the need of increased mimic for the normal physiological response to prevent the hemodynamic instability is needed. Because of this, we have to increase. We have to supplement a dose of steroids for them, and only glucocorticoid supplementation needed, and mineralocorticoid supplementation is not recommended. And usually, if patient is is on oral, can take oral, we have to double the dose of steroids. If patient is not taking orals, we can convert it into hydrocortisone, and it can be given around 50 to 75 mg according to the dose which is needed, which is around 12.5 to 20. And this is the consensus which was released in 2023, and this consensus had around 26 disciplinary clinical experts from various countries, and it is a multi-state consensus unit. And according to this, they have said like to withhold SGLT2 inhibitors, metformin, ACARB, RNA, diuretics, direct renin inhibitors, and NSAID before any volume depletion state, and adjust the insulin depending upon the glucose and ketones, and resume the meds within 24 to 48 hours of symptoms resolution and normal eating and drinking. So as I end my talk, I just want everyone to remember SADMANS. SADMANS, S stands for sulfonylurea, A for ACRB, D for diuretic and direct renin inhibitors, M for metformin, A for angiotensin receptor blockers, N for NSAID, G for SGLT2 inhibitors. And kindly stop these medicines so that patient will not end up in AKI and we can have a proper post-op care. Thank you.
Much, sir. So yes, mnemonic SADMAN, not only a mnemonic. If the drugs are continued, then patient, the operating team, anesthetist, all will be SADMAN. So moving on to the next topic, I think this is the last but not the least final topic for the day. Again, once the QR code will be displayed, so please register for the CME, and I hope my voice is loud and clear. Yeah, so the next topic would be a panel discussion. That's the last final topic of the day. The panelists would be, the panel discussion would be done by our own team, urologist, Dr. Prasanna Ram. So Dr. Prasanna Ram is the ever charming, the youngest of the lot. As I said, similar dialogue as for Dr. Ajay sir as well, who happens to be like almost the same batch as well. So he's one of the pivotal roles in the urology department, one of the senior consultant urologists. So as far as I know, Dr. Ananthakrishnan sir may be the iota of the department, and Dr. Prasanna Ram is surely the renal artery, one of the renal arteries. The other renal artery is actually operating in the theater right now, Dr. Manas. Yeah. On that note, the panelists were supposed to be Dr. Ananthakrishnan sir. We have our senior consultant anesthetist, Dr. Nagaswamy sir. I think could you please, they'll be sitting there. Nagaswamy sir, could you please take the seat here? The camera would pan to you, sir, for the next forthcoming discussion. The other panelist was supposed to be Dr. Ananthakrishnan sir, but he has gone to the theater right now for an emergency case. So this panelist would be headed by Dr. Jyoti Shankar sir. He's our senior consultant gastroenterologist. Please, sir, could you please come see. Senior consultant gastroenterologist who plays the pivotal role in taking care of other than urology cases of our particular institute. We are very proud to have you here, sir. Thank you very much. I think over to you, Dr. Prasanna sir, for the next panel discussion.
Nadia. Is it okay? இப்படி போட்டா சரி இல்ல இதை இப்படி It's okay. Good evening, everybody, and welcome, esteemed panel members. Today, this is a problem-based learning session on when ERAS appeared to fail after radical cystectomy, or did it really fail? So I'm Dr. Prasanna Ram, and I'll be presenting the case, and we'll be discussing with our esteemed panel members. So now this discussion is about what happens when a well-derived design protocol meets a real-world patient physiology, especially in a case of radical cystectomy. So as you know, any of these surgeries that involves resection and anastomosis, they tend to give a lot of stress to the patient's physiology. So what are the objectives of this discussion? It is to review the principles of ERAS. Firstly, a brief revisit on what ERAS is actually designed to achieve here, and also to walk through the real-world problem in a case, and to analyze why it appeared to fail, and also to extract lessons from these so that it might help in our future practice. There's always a dogma in, when it comes to surgery, especially things like prolonged pre-op fasting, drains, and prolonged bed rest. This was followed for many years, and precisely why ERAS was starting to be implemented. So now, what are we trying to achieve here? So ERAS is fundamentally, it was started only prior to reduce the surgical stress response. Now, everything else comes from there. The early feeding, the early mobilization, the early discharge, all of it flows from that single principle. So if the stress response is not adequately attenuated, then what happens? The recovery gets delayed despite following any sort of protocol. So now when you come with the case, this is the case that where, the expectations of the treating surgeons and the anesthetists, it kind of diverged from what we expected. So the reality was different. So coming to the case, it was a 75-year-old diabetic male with locally advanced muscle-invasive bladder cancer. Transurethral resection of the bladder tumor was performed in September 2024, following which he had 4 cycles of neoadjuvant gemcitabine and carboplatin. Here, it's important to note that carboplatin was given instead of the standard cisplatin. That is because his renal physiological reserve was low, his EGFR was below 60. After the 4 cycles of neoadjuvant chemotherapy, the patient underwent a FDG PET-CT, and which showed partial response. So the decision was taken after counseling the patient adequately to undergo a radical cystectomy with an ileal conduit. So here now, what do we do? So ERAS, if you notice here, this is the overview of the pathway. And it's not a single post-operative checklist here. If you notice this, it's a continuum. So pre-op optimization, intra-op control, post-op recovery, and finally auditing. This, at any point, if you fail, it might affect the downstream outcomes get affected here. So now, initially, if you see, this is a patient on paper, he was supposed to be very suitable for ERAS. He's a 75-year-old male, he's a diabetic. His this Eastern Cooperative Oncology score was 1, which means he was able to carry out his own work. He was moderately built. His renal physiology was obviously altered. His creat was 1.6, his total GFR was 48. And his risk stratification as stratified by the anesthetist was ASA 3. So, however, see, if you know, keep in mind here the age, the diabetes, the prior chemotherapy, and his borderline renal functions, all of this already suggests a reduced physiological reserve. So this patient was compliant. Yes, in terms of his compliance was good. There was no prolonged fasting here. It was avoided. Carbohydrate loading was given. Now, coming to the case, intraoperatively, surgical approach was a robotic, minimally invasive approach, robotic radical cystectomy and ileal conduit. Total duration of surgery was 6 hours. The blood loss was around 300 ml. Maintenance intraop fluid was adequate. The only thing to note intraoperatively was dense adhesions that was seen around the left iliac node. So you had a large raw area, which was a metastatic raw area, but at the same time, it was densely adherent. Temperature maintained intraoperative was all right, and no hemodynamic fluctuations. The diversion technique was the ileal conduit, and the nasogastric tube, as per our Curie institutional protocol, was kept for 24 hours. Multimodal opioid-sparing analgesia was used. So now, what was the plan? Post-operatively, the ERAS plan was early mobilization, early oral intake from day 1, opioid-sparing analgesia, early removal of tubes and lines, and we thought, as usual, post-op day 6 or 7, within a week, the patient gets discharged. Now, where did this deviate? So if you see on this first post-op day, as per the institution's protocol, we started liquids at 30 cc. Our RT was aspirated every 2 hours. First 2 days, he was okay, he was ambulating. The third post-op day, patient started complaining of increased pain and features of ileus. Abdominal distension was noted. His abdominal girth increased from 1 from which was prior, it was 101, it jumped to 109 centimeters. And we performed a CT scan after which we saw dilated bowel loops. There was no obvious transit point. So we passed a flatus tube. Flatus was passed and the parental nutrition was started. So then coming to POD 5, his abdominal girth started decreasing. Orals were increased slowly from 30 cc and went on. By POD, the 9th POD, his semisolids had started, and his 11th POD got discharged. So this is usually about a week more than what we take to discharge the patient. So case timeline, a capsule, this patient was actually, he was ERAS compliant in the beginning. If you look at the timeline, the key post-op event here is on POD 3, where he developed the onset of ileus. Here, it's important to note that there was no anastomotic leak, there was no sepsis, and there was no other major complication. Now, the recovery was delayed, but it was not derailed. So now coming to our esteemed panel members, sir, one of the, obviously the audience and the questions that are here that we'll put forth to you now is, here in this case, did ERAS fail? Or you feel the patient's biology overrode the protocol, sir? Was compliance followed well, and were our expectations realistic?
Thank you for the opportunity given. First of all, I thank Curie and the management for inviting me to take part in this wonderful session. Please permit me to go through my professional journey of more than half a century. 1975, I joined anesthesia as a fresh MBBS graduate without qualification, and I was trained in anesthesia by my seniors, who were also just MBBS graduates. And for almost 1 year and 10 months, I worked as anesthetist after having learned a few techniques of how to induce the patient with an intravenous agent and then intubate him and then maintain anesthesia with oxygen nitrous oxide and ether or trialing, those inhalation agents which were available in the 70s and 80s. From that period, now we have come to this particular topic of ERAS. When I heard that word ERAS, ERAS as ERAS, there was a theatre in Adyar on Lattice Bridge Road called ERAS Theatre, where a lot of blue music used to be displayed. But then coming to the actual point of it, I had my early practice in ENT anesthesia, where I was doing a lot of tonsillectomies, adenoidectomies, and mastectomies. And the surgeon happened to be my own cousin. And we had a small theater in my upstairs of my own residential building. And we had a small Boyle's machine called Boyle Cadet, which had only a cylinder for oxygen and nitrous oxide. And the patient will be seen by the surgeon, and he himself was practicing as anesthetist for almost 3 years in Coimbatore Medical College. So he was a daredevil surgeon, and he used to say, "Thambi, na paathutten patient, he is fit." And mostly it will be children. So they come on starvation, we induce them with tapentone, give succinylcholine, intubate the patient, and he will complete the surgery within 10 to 15 minutes. And I used to recover the child. And after 3 hours, we used to discharge and send the patient home. So this was the shortest, earliest recovery I have had. And I have done almost about 800 to 900 cases without single mortality in that period itself. And there was no pulse oximeter, there was no ECG monitoring or gadgets that were available. It was only a hand on the pulse, and the color of the blood used to be the guidance for oxygenation. From that era, when we come over to that, when we do more major cases which are time consuming and involving the peritoneal cavity, and surgery becomes a very planned trauma. It is nothing but a planned trauma. We know what are all the steps we are going to do and how much of pain it is going to cause. And when molecular biology improved, we came to know about the neurohumoral changes that take place in the body. So we were able to counteract that changes so that we can maintain the milli-interior to the closest physiological limit. That was the idea with which Professor Kellett thought of this early recovery after anesthesia and surgery. So in this position, not all cases will be suitable for that. So probably this would have been a failure from your point of view because it is not going through the routine run-of-the-mill as you expect, because the preoperatively something would have been missed in this patient. And that is the reason why there was ileus. Normally, when you remove the NG tube, earlier we were thinking that as a anesthesia postgraduates in Stanley Medical College, we used to have at least 3 GJ vagotomy cases in every surgical list. And there they open the abdomen, handle the stomach, handle the intestine. So paralytic ileus is a compulsory thing which happened in the post-operative phase. And we used to retain the NG tube and keep on aspirating it so that nothing accumulates in the stomach, which prevented the contraction happening, which we realized later. And that is the reason why now we allow fluids to be taken even 2 hours prior to surgery so that the normal bowel motility will happen. And early feeding also gives a satiety to the patient, and psychologically it improves the patient's mental behavior, and they are able to tolerate the pain. They don't worry about the pain that much when the feeding is done. So all these things resulted in early bowel movement, motility happened, and platus was passed, and there were no issues. Even when you resect a small portion of the ileum and make a conduit out of it, and remain, rest of the bowel is in continuity, by the time the stomach starts the motility, it gradually goes down to the small intestines, and then there is no issue of ileus happening in these cases at all.
Yes.
But if we have missed something in the preoperative counseling and preparation, then this could have happened. That is one possibility what I think of.
Right.
Okay. And the second thing is, when you know that it is going to be a stressful procedure, we always plan for adequate intraoperative analgesia. As a patient, I had a CABG done in 2016, and I was thinking that I'm going to have a severe sternotomy pain. But to my great surprise, next day, I was absolutely fine. I didn't feel an iota of pain, and I was mobilized on the very next day. And I wanted to see the intraoperative anesthesia chart. And I asked my student who was there in the theater to bring the chart. And no, the same multimodal anesthesia, especially giving ketamine intraoperatively for a cardiac patient throughout the procedure, made a wonderful change, and I didn't feel the pain of being initiated overnight or the next day line pain. Nothing was there. So it was a wonderful feeling that I had, and I was discharged on the 3rd day. So this is possible even after cardiac surgery. So ERAS is a factual thing. It is not something that you dream about or anything. It can happen, but it has to be done in the proper way. That's what I think.
Thank you, sir, for such insightful and thorough explanation. Now, Dr. Jyoti Shankar, sir, our next question. In this case, was ERAS actually followed, sir? The checklist review, it shows that there was overall compliance, but did you feel that there was any partial deviation from the system? Did minor deviation have a major impact? What is your opinion, sir?
Good afternoon, Prasanna. I was actually personally involved in this case. So I was referred to me when we went to the EA. But before that, I'd like to say it's a very interesting topic for the upcoming doctors. So when I was doing post-graduation, they didn't have the staff called ERAS. I remember during the MSday, patients used to stay in hospital for a week after inguinal hernia surgery. Till Sivaraman used to be in hospital. We still talk to my clients and say, no patients go the same day or the next day. What has changed? Still, even now I do open inguinal hernia, patients go home next day. Same thing I did 7 years ago, 30 years ago. Patients were going home after a week or 8 days. So what has changed? The most important thing is awareness and education. Apart from all the protocols we're talking about, is how we prepare the patient for the discharge. The most important thing is giving the confidence to the patient in the OP room. The patients are always in fear. The patients who come into the hospital, they come with umpteen number of anxiety, fear, and always worried the surgeon is going to say something doesn't suit their idea. So getting them prepared for the surgery is the most important thing for an ERAS. We talked about the technical part of it, but how do you get the patient ready? So the most important thing is to explain to them what the surgery means.
The first thing I ask a patient when they come to the clinic is, do you know what a hernia is? Do you know what a gallbladder is? So we'll start off discussing the anatomy to the patient. So bring them into your books, tell them what it means. So half the fear is taken off. So you can get them ready for discharge. Now, the most important thing is to bring awareness to the staff and the junior doctors in the ward. The ERAS concept will fail if the staff and junior doctors are not aware of it. The consultant anesthetist, consultant urologists or surgeons alone know. I don't think the ERAS will succeed. Every duty doctor, down to junior most nurse, should know what ERAS means. Because I saw a patient some few years ago here after hernia surgery. Next day morning, patient was still nil by mouth. They are not given water because they're scared that patient will get obstructed. So these are the things, we need to bring the whole team into the and coming to your case, I still remember this patient bringing a lot of high volumes of bilious acid. So it resembled as the patient had a small bowel obstruction. That's when we ordered a CT, but the abdomen was soft. Remember, there's no peritonitis. And there was always a feeling whether this patient may need to go for a re-laparotomy, a re-look into the abdomen. But I think, remembering this patient, probably the patient had adhesion, some element of adhesion causing bilious. Not acute thing, but there was definitely a hold up somewhere in the distal small bowel causing the large amount of bilious outflow. I don't think it failed. I think it got delayed. So I've seen patients doing a small lateral wall hernia going into ileus for a week. We always say abdomen is Pandora's box. Even after so many years being in abdominal surgery, every other patient is a different patient. We follow your rules perfectly, and the outcome may be different. So I don't think anything taken here. It's probably, we have to be aware that we are not God. We have to be ready for any outcome. The lesson to be learned here is, you follow your protocols to your best. And if it doesn't work, it doesn't work. Because you have tried your best. But in this patient, I think it's only a delay because of the long surgery, I think. I don't know the previous nutritional status. Sort of cost yes. Sometimes, patients don't eat for months together. The bowels become atonic. So they don't recover quickly post-op. But I've noticed a lot of patients,
Yes.
The fear of cancer, they stop eating. They eat very simple food. They eat curd rice or rasam rice, no vegetables, no electrolytes, no good protein. The bowels become atonic. And post-op, this patient go into EA. So
Yes.
a lot of
Factors.
social factors, the emotional factors. So the delay in this case is probably an exception.
Right.
But I think you guys did a good job.
Thank you, sir. Thank you, sir, for the opinion.
Sorry for the question. So we have a question from the audience. We have an esteemed member in the audience. His name is Dr. Vijay Kumar. He happens to be the president of Indian Association of Parental and Enteral Nutrition and also founder president of South Asian Association of Parental and Enteral Nutrition. He asks, what do we actually mean by ERAS suitability? All elective surgeries are suitable for ERAS protocols. No need to keep RC for more than 1 day. And what is your take on CHO loading? And ERAS will deliver maximum results only when we try to adhere to it as maximum as possible. So you take on this, sir?
I think Dr. Jyoti Shankar sir just stated that as compliance as much as possible from the patient and our side will possibly guide the outcome. But RT, yes. Because as sir said, there was excess bill, more than what we expected, more bilious production than what we had expected. So, yes, sir. So we do, as part of our institutional protocol, we give a carbohydrate-rich drink 6 hours prior to surgery, sir. So again, as part of the ERAS checklist that we follow. And
this case had a secondary the PET scan.
right, sir.
So would it have been a reason for?
Definitely, sir, because of the fact that if you take his European Eastern Cooperative Oncology Group, that is the ECOG status, that what we see, performance status of the patient, and combine that with his anesthesia ASA3 and his renal physiology being decreased because his creatinine was 1.6, his EGFR was less than 60. When you put all these factors and the fact that he's undergone 4 cycles of neoadjuvant chemotherapy, all of this combined, acting together, might possibly be one of the reasons that certain things might have gone away from excellence. Yes, sir. Yes. Right, sir. Which means his gut will not respond as well as a normal person.
Like to add is, even doctors want to follow ERAS, some of the patients are not willing to follow ERAS. They say, hospital is not for it, we again, figure out. So you have to listen to the patient sometimes. So ERAS is for the patient to
Compliant patient.
They have to be compliant.
Yes.
Otherwise it doesn't work.
Thank you, Joseph Ganga sir and Nagaswamy sir. Now, so when here, if you see why it appears to fail, is this an illusion of the ERAS failure? Basically, these 4 broad factors: the patient's biology, the surgical stress, possible partial compliance, and some systematic constraints that happen. So then we come now here again back to the question, back to the panel. So biology often trumps the protocol. So with this patient, as sir had rightly just asked prior to this, the inflammatory response variability, sir. What is your take on this? The gut handling, the ischemia, and its relation to the overall outcomes of the patient?
Definitely, the DI surgery. In the era of laparotomy, I think the bowels were exposed constantly to atmospheric air, so the bowel constantly getting cold, so the recovery is definitely delayed. With laparoscopic robotic surgery, the gut handling is reduced a lot, and also the gut cooling also is reduced. So the ERAS protocol is much more easier to follow with the robotic and laparoscopic era. And also, as you said, the pre-op nutrition state is very important. The frailty is very important in the post-op recovery.
A 75-year-old male here, so obviously.
Most of our 70+ people, I think the nutrition state is very poor.
Yes.
And they constantly, their potassium, magnesium, and sodium is on the lower level to do a check. And this impacts gut motility.
Right, sir. Sir, then coming next, was this an illusion of ERAS failure? Here, what is the opinion, sir? Did it reduce the risk or did it eliminate it? Was this an illusion of failure or was it a real failure?
I don't think it failed actually. This is ERAS couldn't be followed in this patient because this was an exceptional, we call it post-op delayed complication.
Yes, right.
So I wouldn't call it a failure.
Deviation.
It didn't work for this patient.
Right, a deviation slightly.
Deviation,
Right, sir. And to elaborate on this point, failures often, it is delayed recovery. It is not a catastrophe. So now, what does the literature say? So the literature obviously states that it consistently, throughout literature, as my colleagues had earlier stated, that it reduces the length of stay, the ileus rates, but it also at the same time does not abolish complications. As both our esteemed panelists repeatedly have stated in their vast experience that despite following a lot of checklists and a lot of protocols to the T, patients' outcomes do vary. This is something that has to be kept in mind, especially in surgeries of the gut and the bowel. So now, the common reasons for failure, sir, you think in this patient, partial protocol compliance was one of the reasons, sir, that possibly delayed the outcome? Because like what an esteemed member of the audience had asked, Ryle's tube should be removed on the first day according to the checklist, but we had kept it due to increased bilious aspirate. In your opinion, do you think that could be a possible reason, sir?
something has been missed in the pre-operative phase of counseling and the evaluation. So if that has been done in a little more detail, especially when you know that the patient required neoadjuvant therapy before surgery to reduce the bulk and mass and spread. That is definitely not an ideal case for probably to do the ERAS. There should have been a much more workup done to prepare the patient, and then the surgery could have been taken.
Right, sir. Right. Sir, and of like what you said, sir, system level limitations here. Here, the patient, like what you stated, his physiology was already compromised. Right, sir. Sir, the learning point here, sir, is ERAS, is it a rigid rule book or does it require individualization, sir? And requires individualization. Here, compliance, coming to compliance, will each step, does it compound the risk? Are we allowed to change steps based on each patient?
Definitely. I think you have to listen to the patient all the time.
Right.
Patient says they're not able to eat, you shouldn't force them.
Right, sir. Very.
See, the body gives signals all the time. They say
Right.
they're hungry means they want to eat.
True, sir.
They say I can't eat, I'm feeling full. Can't say you ought to eat. You have to follow the ERAS
Protocol.
So patients, you need to listen to patients all the time. The customer is right, patient is always right.
True, sir.
You
Very
listen
true.
to the patient,
Yes, sir.
you
Very
win,
true.
you win. You
Very
win.
true. Very true, sir. Well said, sir. So what does ERAS success really mean? So the ERAS success is not only early discharge alone. It is also harm reduction, early recognition if any deviation has happened, and timely escalation and safe functional recovery. And sir, in your experience, is this insight pertinent to this case? ERAS did not fail. It revealed the limits of protocol-driven recovery. What do both our esteemed panel members think? Is this insight correct?
Yeah. Totally agree with it.
Right, sir. So insight 1 is correct. And coming to insight 2, delayed recovery is not failure, unrecognized deterioration is. What do both of you think of this, sir?
True. Because it's not a failure, because you always learn, so that you do a better job with the next patient.
Right. Yes, same. Right, sir. Yes, sir. Absolutely, sir. So coming to the take-home messages, finally, ERAS does not fail. Mostly the systems, in a way, or expectations do. Radical cystectomy, especially for urologists, test the limits of ERAS because it's a maximum amount of physiological stress on the patient's body. And of course, continuous auditing and will eventually improve outcomes. Thank you all. Thank you, esteemed panel members, for this insightful discussion. Thank you.
Thank you so much, everybody, for this. Especially thank you, esteemed panel members. This was such an insightful discussion. I think one point here is that this enhanced recovery after surgery is mainly for big surgeries, I would say. Because these protocols, especially in the field of urology, they exist mainly for radical cystectomies. Nowadays, it's coming for radical prostatectomies also. But radical prostatectomies of late is becoming, because of the numbers and because of the extensive surgical workup that is going on, the patients get discharged very quickly in radical prostatectomy. So the recovery is actually easier in radical prostatectomies. And cystectomies also involve colonic diversions. For urinary diversions as well. So that has also contributed to the ERAS for radical cystectomy being a bigger procedure. So thank you so much, sir. We have one more question in the chat box by Dr. Naveen, that Dr. Satish, sir. So what is the role of PBM, patient blood management in ERAS? Over to you, sir.
Yeah. Thank you for that question, Dr. Naveen. So PBM is patient blood management. Again, looking at from the perspective of inflammatory cascade, the patient is going to bleed a lot. That means it's going to lead to a lot of inflammatory response. And if you're going to transfuse, again, it's going to bring in a lot of problems like inflammatory cascade, risk of infection, and in patients who are suffering from cancer, immunomodulation, which can lead to a recurrence of cancer in the later dates. So in the first place, we do not want our patients to bleed that badly. So that is why we bring in all the efforts to optimize the patient even before the start of surgery. And by chance, if the patient is going to have some sort of bleeding in the intraoperative period, we would like to have the threshold somewhere around 8 grams per deciliter. And if possible, if economics allows us, we'll be instituting processes like blood salvage as well in the intraoperative period to limit the side effects of transfusion. So that is insofar as how we practice blood management for major surgeries in QRI. Thank you. I hope that adequately answers your question.
Thank you.
Yes, Dr. Sadesh. Thank you.
The chat box. One of us will surely respond to you. And any questions in this thing? There are a lot of postgraduate residents here. Any other questions do you have? Yeah. Yes.
Respect to intraoperative fluid management, what is your takeaway on intraoperative fluid management? Is it going to be a goal-directed fluid therapy, or is it going to be liberal or restricted fluid therapy?
Yeah, goal-directed fluid therapy, if it were to use semi-invasive kind of monitors to achieve that kind of a goal-directed fluid therapy, it has to be weighed against the total cost that the patient is going to incur for the surgery. So if it were not for GDT based on semi-invasive monitors, we can use other modalities like pulse pressure variations and kinds of stuff. So using GDTT is probably the best way to go about managing the fluid in patients who are undergoing major surgeries for maintaining euvolemia, so that they do not have any volume overload or at the same time dehydration, which both can lead to increase in inflammatory cascade, thereby affecting the outcomes such as recovery from surgery. So GDT is possibly the best way to go forward for maintaining intraoperative fluids.
And what is your takeaway on the post-operative pain management?
Yeah.
The opioid patches have any role on post-operative pain management?
Pain management is again something that is like something that is having a significant effect in the post-operative course. We definitely would like to use opioid sparing multimodal regimens. If it is a possibility, if there is a chance for me to use a nerve block or regional anesthesia, that would be my first priority. And this would be happening against a background of paracetamol and COX-2 inhibitors. And probably the opioid aspect of it would be opioid sparing, would be used as minimal as possible. I'm not a big fan of opioid patches. If at all I have to use opioids, I have to use in small boluses, like 0.5 milligrams per kilograms of fentanyl and stuff for rescue analgesia alone. But I won't use opioids as a baseline analgesic regimen.
As rightly said, post-operative opioid patches, they doesn't have any role on acute pain management. Rather, they have only roles on chronic pain management. They usually say like fentanyl, if fentanyl patch is being applied, it takes around 24 hours for its onset of action, whereas with buprenorphine, it takes around 24 to 48 hours for its onset of action to reach its steady state plasma concentration. And henceforth, it's always recommended better to avoid post-operative opioid patches and post-operative opioids if needed. Thank you. Thank you.
Thank you very much. Yeah, we have one more question from the audience.
Good evening, sir. I'm Dr. Anusha, Professor Anesthesia from Faciomaxillary.
Good evening, madam.
It was a pleasure being here. Dr. Karan sir is also Professor. Both have come from.
Good evening, sir.
So I have a question, sir. Role of low flow anesthesia in the ERAS.
Low flow is something that is like really close to my heart. And I've seen from my practice that if we are practicing low flow anesthesia, it is like directly correlated with the least hemodynamic disturbances. The patients go in smoothly, the patients come out smoothly, and the patients perform really smoothly in the intraoperative period. I'm not sure of any studies where they have equated low flow anesthesia directly with ERAS or directly with recovery from the surgery. But if I have to speak on an extrapolation from my experience, probably ERAS, low flow anesthesia, probably would have the least effect among all the flow related anesthesia techniques that we have on the patient's immunohistochemistry. Probably low flow anesthesia would be equated with the lowest chances for elevation of inflammatory cascade. Probably is a good place to start. Maybe we'll do some studies on it. Yeah, from my experience, low flow.
Now, opinion on second gas, sir. How whether air, medical air, or nitrous?
Yeah, we have refrained from using nitrous oxide as an anesthetic gas, at least for the last 6-7 years, for plenty of reasons, primarily for environmental reasons. And we are able to provide good clinical benefit with isoflurane and sevoflurane alone, with O2 and air. And whenever possible, we deploy regional anesthesia. And opioids is primarily used for induction and for rescue. Thank you, madam.
As an onco-anesthetist, there has been numerous evidences which have shown that sevoflurane is notorious and significant to cause cancer recurrence, especially in case of breast cancer surgery. But even then, these are being proved only in animal studies, but evidences are lacking in human studies. So as a general, they usually recommend to go on with TIVA, especially with propofol, rather than using an inhalational anesthetic. And apart from that, since we are going towards, say, like greenhouse gases, and we are just going towards greenhouse effect, it's always better to go and move on with the TIVA rather than going in for inhalational agent. And even in Scotland, so they have prohibited using inhalational agents. Desflurane has been abolished earlier because desflurane is more notorious to cause greenhouse gas effect. So for nitrous oxide, they usually say like the half-life of nitrous oxide staying in the atmosphere is around 104 years, which means like even it is being exposed and conducted to the next decade of life. So if it is so, it's always better to avoid nitrous oxide and stick on to that. This is my takeaway. Thank you.
Yeah. Thank you so much, everybody. I think we've come to the end of this discussion. So once again, thank you all for being here. The vote of thanks will be formally given by Dr. Shiva, sir. So over to you, sir. Just one thing, after all these things, after all this extensive discussion, what we can say is ERAS is something not to be erased from our memory. It should be raised, it should be praised, and the discussion should be raised in different academic forums for a better patient outcomes. Thank you.
Special thanks to you, sir. So, to deliver the vote of thanks, respected dignitaries, esteemed faculty, and dear colleagues, as we conclude the CME on Curiosity on ERAS updates in 2025, I extend my sincere thanks to all those who contributed to its success. I express my deep gratitude to all our faculties and speakers to their clear, evidence-driven, and practice-oriented deliberations. Your session have enforced the importance of structured protocols in improving surgical recovery. My thanks to Chairman Dr. P.B. Sivaraman sir, Dr. Nagaswamy sir, Dr. Ram sir, Dr. Jyoti Shankar sir, and Dr. Anand sir, Director Curie, and a special thanks to Curie management, respected